welcome to tonight's Academy of Ideas Economy Forum. I'm Rob Lyons, I'm the convener of the forum, and tonight's discussion is the politics and technology of healthcare 2030. So obviously healthcare is front and centre in the news at the moment. The shortcomings of our healthcare system have in many ways been exposed, but on the other hand, the pandemic has revealed the remarkable developments in some new fields, for example, in genomics, in our ability to understand what this virus is, and in our ability to speedily create vaccines. But from an economic perspective, healthcare is hugely important as well. We've discussed the automotive sector at a previous economy forum, and that makes up about 4% of GDP in the UK. But healthcare is more like 10%, and it's considerably more in some countries and likely to continue to grow. So improving productivity might not just be about improving economic performance, but also about our ability to save lives and improve the years that we do have. So we have plenty to discuss. Before I introduce our speaker, a quick word from our sponsors. Many of you will have been at our Zoom events since we went online with the lockdown last year. And for some of you, this will be the first time. And as we like to say, although we're in physical lockdown, we don't want to be in intellectual lockdown, and we've run our events free of charge throughout the pandemic. So if you want to support us so that we can keep doing that, then please do give us a donation. I know some of you have already donated towards tonight's event through Eventbrite, and so thank you for doing that. Better still, please consider joining the Academy of Ideas. It costs £60 a year, or £35 for those on limited incomes. And it makes a big difference to have that regular contribution and that connection with people for us as well. So you can find out about both donations and about joining the Academy by going to academyofideas.org.uk/support. And so, all right, on to our speaker tonight. Professor James Woudhuysen is a stalwart of the Economy Forum. He's visiting professor at London South Bank University. He's co-author of Energize, A Future for Energy Innovation, and co-author of Why is Construction So Backward? James regularly contributes to Sky News and Spite, as well as tonight's talk on healthcare in 2030. He's author of The Political Economy of Informal Events, 2030, and co-editor of the Wiley Handbook of Design and Innovation, 2030. He's basically obsessed about 2030. So he'll speak for about 20 minutes, then it's over to you for your questions and comments. So if I just highlight James. James, we can see the top of your head. That's lovely.
All right. Can you hear me and everything?
Yes, that's better. Just push
better.
Right. Fire away.
So sorry to be so poor at all this. I just want to say that I've got several lessons to give you this evening that I've drawn for this handbook by Wiley, which is never ending, from the COVID crisis. Lessons from the COVID crisis about healthcare in general. And as so often with COVID, it's in many ways just an underlining and an extension of what has gone before, but it also has novel elements, as we might suggest. And the first one is, as Rob's already alluded to, new vaccine development. And we can go into the genome project and all of that, and how that was shared and so on, and then some of the vaccine nationalism and so on. But I think one of the things that's interesting about that vaccine, or the different ones, is how the people working on them often been doing it for years and years. And that's generally the case with biology and with medical science at its pure level. It tends to take decades, and that's what's so significant about the rapid development of the vaccine, even though quite a lot of that was standing on the shoulders of giants. So that's one thing to celebrate, that we managed to get it together much faster than usual, but it's a bit of an exception. That's why it is exceptional. Second lesson is that what Rob referred to already at in his introduction, it's not just COVID that's put healthcare front and center for all of us. It's also not just the funding that we can expect. If the OECD's report on spending in 2019 before COVID was anything to go by, they anticipated higher spending, a lot of it because of higher income, some of it because of the aging of the population. But the prominence of healthcare cannot just be laid at those three doors, because it's a long-standing trend. And Labour started it in '76 with prevention and health, everybody's business. Took a bit of time for it to be taken up by the Tories, but eventually in the '90s, they took up this terribly important cause, which is really what Dr. Mike Fitzpatrick has emphasised, and what is the leitmotif of my talk tonight: healthcare promotion, presented as the empowerment of individuals to make informed choices, or at least the right ones. And the key work to see on all of this costs £100 new from Amazon, but I got mine secondhand for 30 quid, only to see an inscription in it by Kenneth McLaughlin, who writes for Spiked every so often. You know, that whole trend towards lifestyle as an alternative to the development of new medicines, R&D, new technology, new medical equipment, better hospitals, and all of that. That was taken up first more than 20 years ago, getting on for 30 years ago, under the doctrine of empowerment. And really the government later on, 2012, this is an important, very boring looking document. It's not a government document. It was accepted by the government. And if you look at what is said there, it's very significant, 2012. In their summary, page 6, I think, down the bottom, first item in the summary is that
sorry, James, just I think you may think you're still sharing the screen, but I don't think you are.
Oh dear.
I stopped it just to do the intro bit, so perhaps
that's all right. What did you see?
Nothing so far.
I wish you'd interrupted earlier.
Sorry, I didn't realise.
That's all right. Wait a minute. Let me try and get that up for you, because some work went into it. Has it made any sense without the slides?
Yes, of course. Yeah.
Let's try and go. Well, it's not, of course. Hang on. All right, share screen. Why is it so hard for them to do these things? There we go. So that's all right. So we're going to share. Now, can you see the slides?
Yes. So if you put it on screen show now, you'll be away.
I put it on screen show. That's what I did before.
I mean, sorry, slideshow, so that, you know.
Slideshow, yes.
That's what I mean.
I'm so sorry, everybody. Do I get extra time for this? Now, can you see the first slide?
Yes.
No? You can?
Yes.
Can you see that one?
Yes.
Yeah? On the lesson 1?
Yeah.
Okay. And therefore lesson 2?
Yes.
All right. Okay. Now we're winning. All right. I'm so sorry, everybody. You're too polite, Rob. That's not our tradition. And anyway, here's that book that I was referring to, showing that the trend towards health promotion, which is better diet, better exercise, you know, look after yourself, don't take any risks, and all of that, that's been going on a long, long time, pioneered really both by Labour and the Tories, and much more the Tories in some ways. And when the Tories were in power in 2012, here's the document I was referring to. No, not a government document, it's lots of clever medics. That's interesting, isn't it? Does anybody know, I don't know if people saw my tweet today, what is the subject of Ursula von der Leyen's master's degree thesis? Anybody know? Public health. It's all about public health, right? She's a doctor, and she's been accused of plagiarizing her PhD in the medical field, but let's not go there. But, you know, the concern with public health, with lifestyle, with diet, with exercise, and with all of those things, walking strategies and so on. If you look at this document in 2012, think it says something very significant. If you can read the blue bits, can you read the blue bits, Rob? Great. It says, it confirms that health promotion isn't just about health. It's about making every contact count. And in fact, they make that phrase, make every contact count, from the professional to the patient, 26 times in that document. So what I'm here to say is that really, if you look at the trend towards medicalization, it's long-standing, and it is about reforming behavior. It's presented as empowering for people, but it suggests, doesn't it, that lots of people are irresponsible, that it's time to be responsible. And we can see with passive smoking some years back that if you were irresponsible in particular domains, then that would carry over in a sort of anti-John Stuart Mill way to, hurting other people. So let's not forget that this is also the era of antisocial behavior orders and all of this. So I think the medicalization of politics, where healthcare becomes center stage, front and center, as Rob put it, is a very important aspect of what we've learned from COVID, where it's dominated our consciousness. And obviously the converse is also true. We've not only medicalized our politics, our society, our everyday life, but we've politicized medicine, and many disputes in medicine breaking out at any moment in time. And one of them, just to illustrate, is not so much the controversy, do masks work, but am I alone in being confused about which masks I should wear, when, how often I should wash them, should they have filters, what their names are, which ones are effective, can I carry them in my pocket? It's what we do with masks that, seems important, and that isn't much disputed, but there is a lot of disputation as to political disputation about medicine nowadays. And another thing I think we've learned from all this is that if you look at the testing that was done at the Lighthouse Centre in Milton Keynes, the Alan McNally was quoted there as saying that if you don't put the barcodes on the tubes for the samples the right way round, you can't do any testing. So one of the things I think we've learned is that IT has its points, and we'll come back to this, but that, when the rubber hits the road, because medicine is about people and about samples and about flesh and blood and so on, IT doesn't do it all on its own. I mean, that might come back to that. Now, a third thing that I think comes through is that we've all heard about comorbidities. And we now know, don't we, that if you are obese or diabetic or something like that, you're more likely to get the COVID disease. And that's part of a wider thing where already it was happening before COVID, that life expectancies were going up. You had the aging of the population, and therefore the famous shift from acute to chronic care, the famous shift, as we'll see in a moment, from heavyweight surgical hospitals to outpatients, local health centers, and a generally decentralized way of dealing with old people locally and in their communities. So what COVID underlined was the vulnerability and also the longevity in many ways of the population and the trend towards chronic care. And in all of that, that's tended to accelerate the health promotion agenda, because if you know that you're more exposed because you've had the wrong lifestyle, then obviously you could be subject to a health promotion campaign and so on. Now, I spent a lot of time looking at the whole question of ventilator production, And before you all fall asleep, I found out that it is conventional intensive care ventilators, for all their faults, are enormously complex animals. And if you look at this Medtronic chart that I drew up, or table from various sources, you can see the prices, the size, and the weight, and you're looking at more than 1,500 parts. So to make these things and to operate these things is a skill-intensive, team-intensive business. And you've got to ask yourself, what are you doing? What are your objectives in all of this? Because there's some controversy about how good ventilators are compared with other equipment and now drugs and other treatments. But in a complex device like this, you've got multiple objectives, multiple people working with them, different people putting them together. I can't dwell on it now, but one of the things that comes out of this whole sort of specialized nature of medical care, and may partly account for Rob's 10% of GDP, the fact that you can't standardize it very easily, that when the IT rubber hits the road, things can go wrong, that you've got these very complicated pieces of equipment, is that what we've also learned, I think the vaccine nationalism discussion, I'm not going to get into, reinforces this, is that shortages of ventilators and equipment generally, it's not just about ventilators when we're looking at medical equipment, will prompt import substitution and attempts to be autarkic a bit in medical equipment, because you've just got to have those kinds of skills on the ground in manufacture for the next medical problem that breaks out. Already the UN is active in Africa, trying to get them to build indigenous manufacturing to deal with these kinds of things. The final thing that comes out of this is that you tend to get rival manufacturers. This is a $300 not for intensive care ventilator machine, which you pretty much hand operate, not quite. And that tends to produce political controversies as well as to whether the people operating those will have the new skills that are required, and whether they're just stopgap cheap products made for publicity purposes rather than the real deal. I'd rather be on a heavyweight ventilator myself if I had to endure one. All right, now we've learned that we can build nightingales. Let's not go there fast, like the Chinese have built new hospital development very rapidly. But one of the things I think we've also learned is that, although I was always very hostile to the 60s theory of it, 70s, Ivan Illich, and medical nemesis, iatrogenesis, the doctrine that doctors gave patients diseases, I think it is fair to say that we're all a bit nervous about going into hospitals nowadays and catching COVID while we're there. This is where this iffy adjective, which I venture to pronounce as nosocomial, but I can stand corrected on that, has come from, right? Which is that hospitals can be built fast, but things go wrong in them. Quite a lot goes wrong in them. Usually that's laid at the door of staff. The OECD just did a report on that. And it's not laid at the fundamental door of low productivity. I could have said more on this. In healthcare generally, low automation, labor intensive, long hours, all the things that we know about it, despite all the ventilators and the medical equipment and some new hospitals planned and so on. The errors that hospitals are prone to, in particular around hygiene, are usually blamed on the health workers, not the poor investment, the low productivity growth, and so on. And yet you can get a device like this, which, as you can see, is fairly small, a bit bigger than a microwave. If you scrape up any gunge from a hospital, it'll tell you whether you've got MRSA within 5 hours. That is a remarkable achievement, where you can detect staphylococci and all these horrid things so fast. So we also need the ultraviolet robots coursing the corridors of hospitals, blasting the virus if that is genuinely scientific, I hasten to add. I like the idea of them anyway, but that's generally not what gets the emphasis. It's not automation. It's rather, the sort of it's your fault mentality. And certainly, I just want to say, not got a slide on this, the old agenda about fight the cuts in the NHS, it's much more a question of fight the court cases that you're threatened with, or be in fear of litigation when you're a health worker, from what I hear and what I've experienced. Now, the decentralization trend that I've already referred to in relation to chronic diseases is something that we've seen a lot of with the various testing centers and vaccine centers with healthcare. And they have their merits, but they also promote the health promotion agenda. I think we've got to say that. They are going to be not strong on MRI scanners, and they're going to be more about how are you, what about friends and family? Are you exercising? How is your diet? What about the smoking and all of that stuff? That's what decentralization is about. Probably see a lot more of it after the COVID thing. More shops, Asda, Tesco, more high streets having medical facilities and so on. By the way, there's a trend to lightweight imaging equipment that will work in the same direction. In fact, what's neglected is not just automation and equipment and productivity, but the real crisis that there is with staff, not just in the NHS, worldwide, the shortages of labour, the overwork before COVID was all going on. It's all, and the same with India, where they don't even get paid. But I got all the numbers for this in America. It's very worrying. And the contrast between that, and Rob, I'm aware I've only got a minute to go formally, but if you'll give me the extra time for the break, we're nearly done. The big contrast is between the working conditions of the lower staff and this kind of bureaucratic reporting for emergencies, if you please. It's 2013, but it's part of the preparation for COVID and Cobra and all of this stuff. How the heck are you going to do anything in an emergency? No wonder Rolls-Royce and some private companies and AstraZeneca a bit fleeter of foot than this kind of bureaucracy. And one of the things that's never discussed in the COVID crisis, which I'd love to hear views about, is the role of NHS trusts. There's 250 of them, and they generally employ a whole bureaucracy, and they're all on hundreds of thousands of pounds, and they're all the great and the good, and they're never questioned. Chris Jepson, whatever his name is always being quoted. Nobody ever has a critical word to say of them, and yet I know from direct experience that they are an undemocratic, deceitful waste of space, and much worse. So there's a big contrast there, which I think we need to remember, which is of a piece with the sort of anti-working class stigmatization of lifestyle that I associate with health promotion, which is that the elite in healthcare have formed a new priesthood telling us what we should do as patients, and being very, very different as a caste from nurses, junior doctors, quite a lot of doctors actually, although doctors are implicated in this new bureaucratization process. So just to conclude, IT, I think, has been exposed as meritorious but no panacea. This little electronic nose was going back in 2000, and now by all accounts, I can't get you a picture tonight, folks, the Indonesians have come up with an e-nose for COVID. So no more poking up the nostrils, just wave it, because it takes your breath and detects it. So that's great. And who can argue with that? But I do argue with telemedicine. This is from 1925, because there's no substitute for the doctor examining you and me. And it's got some points, but it's got some real limits. We could talk about, but we won't have time to talk about, or maybe we will, about what all of this IT means for one's privacy, for state supervision, for big tech, and all of that. But I just want to say that the trend towards, to conclude, Rob, the trend towards digital health is a trend towards opening up the self to yet more health promotion, to yet more mental health stuff, to more gadgets, to more Gwyneth Paltrow goop remedies, it's the burial of the self in the new obsession with healthcare. And the IT dimensions of that, if you're wearing a Fitbit and all of these things, no harm at one level. But if you're continuously always on to your health condition in the future, which seems to be where the middle classes will head in 2030 with the help of digital health, those apps on their phones and those little wristbands and all the rest of it, we're looking at something that is not just an invasion of privacy, but something pretty sinister, really, where we're living for good health rather than living life for what it's worth. And that's not just philosophical. It's not just about surveillance. It's just a very misplaced series of priorities masquerading under Silicon Valley apps as the way to go forward. The real way to go forward is to pay the staff more, to train more of them, to invest more in good medical equipment, to downsize it, but not to kind of dumb it down, to bring it to more people, but to make sure that IT isn't a substitute for a proper consultation with a GP who looks you in the eye. Thank you so much.
Thanks, James. So, am I still on? Oh, no, I'm not mute. Good. Hello. Right. Thank you very much. I'm going to take you off Spotlight as well.
Please do.
Right. And you can all see me again, I hope. James, as ever, has covered a tremendous amount of ground, thrown in a few intellectual grenades along the way, and yes, given us lots of food for thought. So whether it's everything from the current state of the NHS to the pros and cons of medical technology and new medical technology in terms of the problems they can solve and the problems that they can't solve. I, for one, have given in and got my skinny little wristband for Christmas, so I am now monitoring myself in all sorts of weird and wonderful ways. I rather love it as well. So if you would like to ask a question, and it could be a really, really basic question, in fact, it'd be great to get some basic questions out right at the start, then you can use the participants button, which should be floating around hopefully at the bottom of your screen, or if it's on an iPad, you might be somewhere else. You can click on that, and then you can go to the raise hand button to indicate that you'd like to speak. You might also find that raise hand button under reactions as well. I think there's an update to Zoom, and some people have got that under reactions. I can see a little blue hand there already, which is Martin Perks. So, Martin, what's your point or question?
Hi. Well, it's a fairly simple point about technology. I take on board all the issues that James correctly talks about in terms of the invasion of privacy, etc. But the problem I have is that, to all its intents and purposes, the genie is out of the bottle when it comes to digital technology. So I have diabetes, and one of the things I do is I have a sensor now that I literally stick onto my arm, and I'm, if you like, part cyborg, part human being in terms of what it does, because it allows me to tap my phone onto it and give me a real-time reading of my blood sugar, etc., which to me is a huge bonus in terms of being able to, self-monitor and, to really understand better than I think a physician can do in terms of my own situation. And I think that, so I obviously appreciate the privacy issues, which is, can be quite considerable, especially when we get to the whole behavioural nudge side of things. But however, at the same time, when we're faced with a horrendous bureaucracy that is the NHS, under-resourced, and all those issues that James has highlighted, surely we're in a better place at the moment using digital tech. So again, come back to the point, the genie is out of the bottle. So where does James see that or sit on that question, and again in the future? Because there's no going back to kind of removing these devices from ourselves.
Great start. And for AD, can you unmute yourself?
Right, sorry, I was being told I couldn't unmute for a minute.
That's right.
Right, we're on now. Thanks, James. Really, really interesting. I'm myself have always regarded myself as being a bit of a technophobe, which James knows. So he'll probably be a bit surprised at my take on this. But I really wanted to follow up on what Martin, I think, was just saying about some of the brilliant things that I think the whole recent review, the whole recent period has forced us to rethink in terms of the way that our existing NHS works. I just stepped down from running a non-profit third sector organisation that provided a third of all of the terminations of pregnancy in Britain, commissioned by the NHS to do that. And the introduction of telemedicine into that sphere has really demonstrated, I think, to us the old idea that it is better to be in front of a GP or a physical counsellor than to have a consultation online can actually be an utter myth. Everything depends on the training of the person who's doing it. And that, in fact, particularly when we're talking about today's young people, they're far more comfortable interacting with their phone on chat or in a Zoom conversation than they are just kind of rocking up to a clinic. The ability to send people medications by post and so on is it is really a way that we've been able to transform a very large part of our service. And I think what I'm really saying is that, and I'm sure that James would agree, is that it's not a question of telemedicine good or bad. It's a question of what you use it for and how you integrate it into the systems. But what I do think is really good is the challenge that it's posed to the NHS bureaucracy in terms of shining a spotlight on their complete bureaucracy and inefficiency, and this notion that it really is this sort of saintly institution that can't be criticised and is the best in the world, because largely the running of it is basically pretty crap. So I'd like to know what James thinks about that.
Great, thank you very much, Anne. Both those contributions make me think about the question of this idea of healthcare becoming a more and more substantial part of GDP, of our economy, and whether that is just an endless process, that as we medicalize our lives, that healthcare will just burgeon, and maybe that's fine, because if our economies grow, we've got more disposable income, or more income in the economy in general, that actually we can devote more of our resources to healthcare, whether it's improving our monitoring of things to make sure that people live longer and live better quality lives, or whether it's to avoid death or whatever, that we can do that. Or whether that is a problem in some way, do we think that actually that's a diversion from perhaps some more useful things, as James ended his comments about, we have to sort of emphasize the whole process of living, not just merely the prevention of dying. So any comments on that or on anything else? Otherwise I'll bring James back in for some initial responses. You're all being very shy, you're all overwhelmed, so I'm going to bring James in. Just initial comments on what's been said so far. James. You're not on. You're on mute. Sorry, you're on mute.
Hello. Is that all right?
Yeah.
You know, in case anybody's bewildered and doesn't know where to jump in, I mean, what I tried to do in the talk was supplement or mediate the Mike Fitzpatrick agenda on health promotion. And I'm careful not to pose it as a method of social control. I think it's much more unconscious and long running than that. To contrast that, which is around lifestyle, with the weakness around, the general weakness around R&D, medical equipment, hospitals, quiet hospitals in particular, and everything else. That's the substance. That's the way I've tried to develop Mike Fitzpatrick's work, by mediating it with the Phil Mullen perspective, really, you know, in terms of the need for some creative destruction and real innovation, such as we've seen a bit of. Now, it's always lovely to be told that IT is good news, and I fully accept that the examples that Martin and Anne have adduced to do with the little button on Martin's arm that tells him where his sugar levels have got to, and the medicines by post, charmingly old-fashioned, and Anne's very substantial point about the success of telemedicine depending on the training, presumably both of the patient and of the doctor, Anne, but I'll leave you to comment on that. I think it's right that it has shone a spotlight on the bureaucracy. So I've got no quarrel with the upside of IT. I think we're familiar, aren't we, that with the idea that technology generally depends on how you use it, who's using it, and for what end. And I just want to draw attention in what I did to the fact that even a piece of hospital equipment or a piece of IT has a progressive side, but in the current climate where technological innovation and investment runs second place to the health promotion agenda and the new priesthood come bureaucracy, we've got to take a critical attitude to IT in case it's an unwitting, unconscious, because it's just machinery, participant in that twisted sense of priorities, the one that Rob, is right to focus the last words of my talk on, that by, not through Martin's gadget, but through obsessional and narcissistic focuses on our minute-to-minute health, we can lose the plot. And that is the way direction in which a large raft of the middle classes, especially America, very influential in culture, are broadly going. Now I wear a watch. I like to know what time I'm keeping. I don't have a problem with that. And there's lots of exoskeletons and things like that. Japanese have come up with a tail which is made like a seahorse tail that can help old people like me balance properly. It's made of modular vertebrae and has 4 pneumatic muscles, and I'm dying to look a bit like an armadillo with this excrescence that is IT assisted. Same with the robot cleaners. But at the same time, we know that these exotic examples apart, just as we're nervous about working from home and living a life of Zoom, I'm sure Anne would accept that, the Matt Hancock prescription, which is that telemedicine is the default option. We've turned a necessity from COVID into a virtue. The right for an in-person consultation is as defendable, it seems to me, as some of the real progress registered by Martin's portable device and injectable device, really, and telemedicine. What is generally the reason I put the emphasis I did is because medical IT has been so uncritically celebrated by many people. And that's why Hancock believes he can get away with it. You know, default option, never go to see the quack again. You know, feel guilty about going to the quack, you know. And I oppose that. I think that would be wrong.
Great, thank you very much, James. Right, a few more hands have appeared now. So Daniel Benami.
Okay, can you hear me?
Yes.
Yeah, I just wanted to say something about the use of GDP in relation to measuring healthcare, because I think it is problematic. I think there are some reasonable uses of it and some unreasonable uses. So I think it's reasonable to talk about, do we as a society think that in the future we need to spend more on healthcare as a proportion of GDP, which James referred to. I think that, you know, it's reasonable to talk about that. I think it's reasonable to use GDP, roughly speaking, if you're comparing the priority different countries give to healthcare. If you're comparing, say, Britain to France and Germany, there's some use in that. Although even then, it's far from perfect, because if you look at the US spends a huge amount, I think it's 18, 19% of its GDP on healthcare. And I think other people here probably know more about the US healthcare system than me, but I think that's at least partly because it's extremely decentralized. A lot of the standards and regulation is on a state level rather than a federal level. So you have 50 different kind of boards approving a lot of ways in which healthcare operates. So it's not even perfect on that kind of level, but you can use it roughly to compare country to country. But where I don't think it's really reasonable is to talk about GDP as part of the economy in the same way, say, that producing cars is part of the economy, or having restaurants is part of the economy. I think it is different, because when people work out GDP in relation to healthcare, what they normally do is they just add up the wages of the total wages in the NHS, in the British case. And then they say, okay, well, roughly speaking, 10% of the wages are accounted for by the NHS, therefore it's 10% of GDP. But that isn't really very useful, because obviously healthcare is in some respects very different from other parts of the economy. I mean, in some respects it's part of the economy, in some respects not. I mean, it's clearly not producing things in the way that someone who produces widgets is producing things. It's clearly not producing things even in the sense that a restaurant or a software company is producing things. But to a degree, it does have an economic role in that it's making sure workers are healthy and they can play a role in the economy, assuming that they're young enough and fit enough to do that. But I think the undifferentiated use of GDP in relation to the healthcare discussion, I think is problematic, because it does often obscure what's going on rather than really clarify things.
Okay, great, thank you very much.
Yeah.
Now I've got somebody called EV297PB. I'll ask you to unmute. Right, so if you can stick your video on as well, it's always nice to see somebody's face when they talk. Thank you.
I used to be able to change that to my name, but I can't seem to do that anymore, and I don't really know why not. Anyway, very interesting discussion, James. I suppose the thing that really struck me about COVID was, and I knew this, but more so now than ever, how fragile our whole health system is. It kind of really impacts on you that the only way they can cope is to stop everything else happening, deprioritizing everything else. And clearly, that in itself is a big question to answer. Why? What can be done about it? Because yes, people should be paid more. We should have more skilled people. But really, I think it's a lot more than that. It's, you know, when you think that the NHS has gone through 50 reorganizations, I think between 1990 and 2009, and each reorganization has probably brought its own problems and made it worse and worse. So you kind of really begin to think that the only way you can even ask the question or answer the question of what kind of a health service do we want is to almost start from a clean sheet of thinking about what is it we need to do, because I don't think anything else will work. So even if you've got more digitalization happening, you kind of feel the impact and the use of it is going to be lost, because it's all sort of operating in a position where there's a lot of bureaucracy. The challenges to the bureaucracy might be there, but are people asking the right questions? I seem to think that most people think just throwing more money at it is going to work, where I would argue that this is the right time to raise the bigger questions as to what the NHS has become, if you like, and perhaps experiment and try out a few things, to see whether we can resolve the issue of where we want to go with the NHS, or health rather.
Okay, brilliant. Thank you very much. That does make me think about the this whole issue of digital IT, because obviously the NHS is famous for having terrible IT projects, and I'm sure that that is not because as soon as people, perfectly competent computer programmers, go anywhere near health, they suddenly become incapable of programming computers, but rather the kind of messy, bureaucratized, not quite sure what we're doing this for state of the way in which we run healthcare today makes it very, very difficult, in fact, to run an IT project to a successful conclusion, because the goalposts are always shifting and the aims are never entirely clear. Jenny, next. Yes, well
There
done.
we go. I don't know where to begin. Perhaps with perhaps with following on from what Pam was saying, the sadness about COVID, right, is it's exposed all the weaknesses, and it's exposed the bureaucracy for what it is. And it's exposed the elite in the NHS. The problem is that the hallowed NHS is beyond question now. It almost seems impossible to actually raise criticisms in any kind of wider sense. And I think exposés are absolutely essential at this time. But the first point I would say is, if you've got an emergency, or if you've got cancer or something like that, right? The best way in our health service is to go to your GP, to have a thorough examination, to be referred to a specialist, to then get into a specialist team, where you'll have some of the best diagnostics, the best treatments, and so forth. But we know that that isn't the pathway, and under COVID, it's completely been abandoned. But, the NHS can be very, very good, and the NHS can succeed. Giving somebody a diabetic implant to monitor their blood glucose is great. It's a really good application of technology. It's a pity they couldn't do it for blood disorders, bleeding disorders, and all sorts of other things. The problem is that diabetic monitor, right, is available to a tiny fraction of diabetics. Most diabetics haven't heard of it, nor will they ever hear of it, because they'll never get it. It's the fact that it's so poorly organized, so bureaucratic, that all the deficiencies gets swept under the carpet. The postcode lottery is still the way medicine operates, in this country. Just two more quick points. The bureaucracy now involves a lot of clinicians. It's no longer just managers and people like that. You wouldn't mind, actually, if they brought in a Sainsbury type manager and actually paid them according to results. That would be great. But what they have increasingly in the bureaucracy is they have clinicians who are unable to advance their careers except by taking on management roles. And the NHS is full of people who have left their clinical work behind and become managers after a 6-week training course in management.
No.
They can sprout all the lingo, but boy, they can't manage. So it's kind of become a bureaucracy which has, if you like, almost infiltrated the medical profession, the nursing profession, and everybody else. And it's turned it into an absolute monster. There's no question about it. And exposure is absolutely necessary if we're going to break through, the idea of this hallowed health service. I'll leave it there. I could go on.
Okay, so Jenny's a former NHS worker, can you tell? Right, on to Phil Mullen, please.
Thanks. James, that was great, and I really agree with your framing of the discussion as this context of the medicalization of everyday life. I mean, just on Jenny's point there, I mean, I'm very sympathetic to what Jenny said and what Para said before in terms of the bureaucratization side. I mean, I think I would put the emphasis more on sort of a 30 years of initiatives from governments of all political persuasions and this process of constant sort of reorganization that's gone on there. So I know James earlier, one of his slides, he was drawing up drawing attention to some of the downsides of decentralization, but I think it's the centralization has also got a lot to answer for. And in a way, what's happening in the NHS and healthcare is really an extreme version of what's happening across the civil service and across Whitehall and across the state apparatus, which is, 30 years of attempts to centralize, to sort of like the Treasury tells Whitehall what to do, and Whitehall through its departments then instructs what happens in the different areas of the state. And the NHS is the most sort of, I think, extreme version of that. And I think the problem then is to be brief, because I want to go on another point, but the problem is really the way centralization has undermined local responsibility. So it's not so much the managers of the problem or the bureaucrats of the problem, it's this whole process of setting the rules, setting the regulations, setting the controls, and then changing them 6 months later. So, and the whole impact of it is to undermine the responsibility locally of being able to take decisions, make judgments, and provide decent health to the patients. So I think it's looking at it as a symptom of the general hollowing out of state capabilities. I think that's what the NHS shows us, in particular NHS over the last year, as Jenny described in terms of COVID. The other point I wanted to pick up on is from what Rob was talking about and what Daniel was talking about, which is the relationship of health to GDP and productivity and so on. And I'll more do this as a question because time is short. But I think Daniel was right to sort of draw a distinction between, you can measure the amount that we spend on healthcare, or any country spends on healthcare, as a share of GDP. But that's very different to saying that healthcare is a contributor to GDP. I mean, national statistics bodies do work out a way, as Daniel explained, as to how you can turn healthcare or education or other of these, what I would call, for more civilizational services, into a contribution to GDP. But it's an artificial statistical device. And I think James, I think, used the term productivity a couple of times. So I pose it more as a question, is that if we are challenging the sort of the medicalization of everyday life and trying to create an alternative discussion about how healthcare should be organized and what it should be about, maybe part of that should be to not use some of these terms of productivity and GDP and stuff, which I think reinforces a very quantitative view of these services, and perhaps come up with a better way of measuring medical progress, which more focuses on the quality of what is provided. Because if you think, just to end with an example, if you think about productivity, generally that means reducing the amount of labor time per output. And that's not something that we should be interested in with these civilizational services like healthcare or social care or education. And there's no point increasing productivity. That means that the doctor spends less time on each patient, and therefore the quality of the care, or each nurse has to run around doing more work and with less time with each patient. So I think perhaps we should, it's not a terminological question, but I think we should perhaps question the whole use and challenge the use of productivity in relation to these services, and work out new ways of coming up with metrics which focus more on the quality. Perhaps, you know, the amount of time it takes to get a diagnosis, the amount of time it takes to, you know, to get to the specialist treatment that Jenny's been talking about. That's a different way of framing the discussion, I think, is what we need to do positively if we are to challenge the overall framework that James described of the medicalization of everyday life.
Great, thank you. I'm going to rattle through some more of these hands. So Sally Millard.
Okay. Yeah, can you hear me?
Yeah.
Okay. It's going on from that point that Phil's just made, really, because I think when someone said it, made the point before that it really, surely the right outcome from a health service is that you no longer need the health service, and therefore you should be trying to reduce the amount of health service we need, I suppose, in a sense. And productivity, maybe we can think of it as, have we cured the person? Have we been able to do that? Have we been able to apply the best that we've got to the particular requirement of that individual who is in front of me? And so it does seem a bit odd to talk about GDP in relation to healthcare. And I suppose it's something that's happened over a long period of time now, where these things are discussed as part of the market rather than a service that is provided to us. That's one thing. The other thing is that I just think there's a real problem with the monolithic body that is the health system, the NHS. And it does so many different things, some of which are fantastic, and some of which are not so great. And I kind of think it's kind of too big to think about in a right kind of way, and we need to separate it off. So I mean, I use the healthcare system. I use it for I think it's great that my prescriptions, I can now just get a repeat prescription through the doctor. He sends the information digitally straight to the pharmacy. The pharmacy sends me a message. I go to the pharmacy. There is my prescription all ready for me to collect. That is a really great thing. I don't have to see the doctor for those types of things. Then I have an annual checkup, a hospital appointment. And this year I had to have that hospital appointment online. And the first thing that the doctor, who normally talks to me, I walk around the room, he asks me loads of questions, he examines me, this time a phone conversation. And the first thing he writes on his letter is, I was unable to see the patient. All I could do was rely on what she told me on the telephone, which is not a good enough thing for a doctor to be able. I mean, obviously this is particular circumstances, you can say, but the idea, I think that's what's happening with GP services as well, that you have this teleconferencing, but really to be able to make a proper assessment of the individual and what their needs are in the round in front of them, they need to be able to physically see the patient in front of them. And I think one of the things around the productivity of the NHS and efficiency drives is that goes out of the window. And instead, I suppose it's the same point Phil's making, really. Instead, we've got this just this drive to, get people through the door as quickly as possible. That's not a health service. The health service is, we want to resist the marketisation of it, I would suggest, and resist the way that it's every part of our life has become obsessed with health. And we want to see it as we want somehow to get it back to being a service for people who need it.
Thank you very much. Thanks very much, Sally. Graham Barnfield. Sorry, I do have to ask you to unmute.
Yes.
Hi.
Hi, I'm unmuted. A point on qualitative and quantitative and how they sort of fit together. We've seen with the NHS, big spends on stuff, whether it's been IT or more recently PPE, and you can point to the figures as signs of kind of public spending, but often they've proved very poor at integrating that sort of stuff into the overall procedures, and so rather like in the 80s where a PC would sit on a desk and it might have displaced an electric typewriter. It's hardly always been drawn into the sort of service and what they're trying to do. I think the other point, I'm at the moment working from home for an overseas healthcare provider, as you do, and it's very striking that the presence of information technology and especially telemedicine is quite a big point in legitimating work that the hospital and by extension that the sort of the health service there does. And so the response to COVID has been to say, because of our existing investment and innovation and thinking this through, we were raring to go. And it's at the moment this crisis broke, all of these systems fallen into place, and we're able to ensure better performance in Italy and other places they would make comparisons to. And in fact, it's partly been the social structure of the place that's given it some advantages. Retirement age is 60, over 60s are pretty segregated from the rest of the population there, and by and large, there's been things that are part of the society where I'm doing this work, which have insulated it from the worst effects of COVID. But it's interesting to see how their investment in technology, in telemedicine in particular, has been then presented as part of the reason for the success story. So just as I think, like James said, how young people, and Anne said as well, young people are much more hip to the use of technology, much more accepting of it and so on. It actually does form part of the argument for kind of rationalising what a lot of places are doing, in response to COVID, beyond whether they've been relatively successful or not.
Okay. Great, thank you very much. Now, I know Fenno and James Matthews have been waiting, but I just wanted to check in with James Woudhuysen and just see if he wants to come back on anything that's been said so far. James? Hold on a second. I'll try that again. Hello. Right.
Yes. I'm loving the discussion, obviously. I think Jenny is really onto something with the managers are often failed clinicians. That's my experience of one of the worst trusts for nosocomial infection, the Epsom and St Helier, which I know well. And I think she's right to say that we need to expose the NHS. The problem that we've got is that, if you took aim at NHS trusts, as I have done, they say, well, you're taking aim at the NHS, you must be a free market fascist or something worse. So we have a problem, which is that the Fabian Labour, Liberal and Conservative, we're all in this together, appreciation of the NHS does tend to freeze out any critics. I would say that the slogan I'm thinking about, taking Jenny's point, is, for a nurse's NHS, not a trust NHS. And that's the kind of spirit of criticism which takes advantage of the very evident class differentiation that's happening within the NHS right now. It's not just the familiar army of pen pushers, it's a distinct priesthood has emerged, which is paid, cultivated by the media, cultivated by campaigners, and all of these things. So just the second point I'd like to make, the discussion on GDP and so on is very worthwhile. Once upon a time, Anne, you won't remember this, I wrote a thing about NHS and innovation, not very different from what I've said tonight. And I remember you got very cross about it because you said quite rightly that you know, you'd had it up to here with brainstorming sessions about innovation in healthcare and the NHS. And I think when you draw attention, and Para drew attention to Phil drew attention to the process of endless reorganizations, you know, the restless state and so on, and the defects of centralization. Defects of centralization very clear in the track and trace and testing apparatus that Britain messed up so much. These reorganizations are what passes for innovation in the NHS. Innovation itself is interpreted as organizational innovation, not technological innovation. And everybody's again it in the way that you were, Anne, quite rightly. It does bring me back to, you know, Martin's point that the genie is out of the bottle. The technology often has some progressive sides to it, but the NHS is becoming more and more of a barrier to technological solutions to healthcare, to what Sally says about, you know, not being a patient anymore and getting on with your life, you know, and all of that. It is becoming a way of life. It has become a religion that you can't criticize. And there isn't an easy way out of that except to put the accent on democracy and the reactionary nature of the trusts and the weak investment. And as Phil says, not to talk productivity, but the quality of the care. And what's really irritating about the health promotion perspective is that it's so misanthropic when medicine's supposed to be about helping people out. You know, that's making them no longer patients. But this would keep them patients on everything all the time with a wristband.
Okay, thank you very much, James. I just wanted to play devil's advocate on this marketisation of the NHS or of healthcare issue, in that I remember living in Edinburgh not that long ago, and on Google I looked it up, and so there's 2 GP practices nearby. One had 2-star rating on Google reviews, and one had my phone just thinks I'm saying okay Google now. And the other one had 4-star ratings on Google. They're both pretty much equidistant, but I was told I could only go to the 2-star one because that was the catchment area, and I couldn't, even though they were basically the same distance away from where I was living. So that sort of NHS bureaucratisation. If I could go where the quality was, then that would be a driver to raising quality, wouldn't it? The same with the bits of the of healthcare that are marketised to some extent in the UK. So, for example, I remember getting my first glasses at the local opticians and not being terribly impressed, whatever, and only having one kind of spectacle that I could get when I was 15 years old, which wasn't great for, you know, pulling but the birds at the same, as we say. But now I can go to Specsavers or Vision Express or anywhere like this, and I can buy my spectacles and relatively cheaply, and I have some choice over the matter, but I can still get free spectacles as well. And same perhaps with dentistry and some other things as well. And friends in Australia talking about, right, the doctor says I have to go get a blood test, and walk down the high street and get a blood test at one of 3 or 4 competing different venues, competing for my business in terms of speed and effectiveness. So yeah, it isn't just, is it really the case that marketisation is such a terrible idea, or in fact is this idea of introducing competition maybe a way around some of these problems with bureaucracy that we have in the NHS at the moment? Anyway, I'm interested to hear people's thoughts on that. Anyway, completely unrelated to that, talk about whatever you want, Fenno. So, Fenno, your thoughts.
I got a bit distracted by what you were saying then, Rob. I hope I can remember what I was going to say. So I guess in terms of genies being out of the bottle, I think one of the things I wanted to mention was, I think you can also say the same about the constant reorganization. So I think there's sort of 2 sides to this. So on the one hand, I think it needs reorganizing. That's one of the implications, albeit that it's, you know, hopefully that would be at the end of a very long multiple reorganization process. but also some of the comments that people have made about, the problems of over centralization, needing to have more autonomy locally to determine how things are run. And just say, I mean, that's very much the direction that things are going in, at least superficially at the strategic level. All the kind of transformation programs at the moment are absolutely about ending competition between trusts and getting them to work together better. Trying to reorganize services around primary care networks so that we work sort of secondary care specialist services work more closely with GPs. And there's quite a lot of positive things in there, actually. And COVID, interestingly, has accelerated some of that stuff. So there's certainly in the first wave, there were some quite entertaining bits where people were noticing the silence of commissioners. And I think, there were even a few articles in the Health Service Journal and things where, it was observed what a commissioner is going to do in the future, because suddenly the kind of the managers that Jenny was talking about kind of grew a pair again and realized that actually they had to decide what needed to happen. So I think there's a few sort of, at least at the sort of level of superficial things, things are heading in the direction that people are calling for to some extent. I guess the stuff that doesn't go away so easily is that the sort of medicalization of everyday life. And that's one of there is something in there about, in a way it's quite helpful as a practicing clinician if you can do more video calling with people, just because you can get through people more quickly. And it's almost that the system creates a problem that it then needs to deal with. Lots of people trying to get to see their GP, for example, with a problem that they don't need to see their GP about. And I wouldn't suggest that that's the main issue, but it's certainly a problem that gets generated by how things are set up. One final sort of question really for James, just in terms of the sort of health promotion side of things, I'm just interested how you see the IT side of that stacking up, because to me that seems one of the areas where, I don't know, IT ends up being like, you get directed to a daft website where you get told 5 ways to improve your well-being or something like that. The sort of more big brothery end of things, the sort of much more high-tech versions of Martin's, blood monitor stuff, that I think that's kind of way beyond the NHS being able to put that into practice. So it doesn't really seem to me to be something that we should be too worried about.
Okay, thank you for that. James Matthews.
Yeah, thanks. So this has been really interesting, and it's hard to get a handle on because it's such a broad topic, right? We're talking about the healthcare sector, broadly everything from the really front end and innovation and through to like the service delivery. And I've got an observation and a couple quick questions. So first, the observation is just from doing some work in the life sciences industries with both pharma companies and medical technology companies. I really notice quite a difference in the morale of the workers and the kind of whole, if to the extent that matters and that drives things, really, this is before COVID. Basically, people in life sciences genuinely believe that they are helping people, that it's like when you go to conferences, when you meet people, whatever. I mean, there is quite a lot of really inspirational kind of talk and why people are doing, and obviously we know this is all mediated by trying to make money. It's to that criteria, but if you contrast, it's quite a contrast, with when you look at the delivery aspect of it, right? Because even though we have a very different system in the US than the NHS, you still have bureaucracy, you still have the frontline workers treated like, called heroes, but, not necessarily treated all that well and not having great, spirit among them. So I just think that that's kind of interesting, just as the contrast in that. My questions, first one has to do with how we would really look at the innovation, maybe from a qualitative point of view in life sciences. there's a thing that's been said a lot recently that's done the rounds within life sciences, which is that Silicon Valley gave us social media apps. Massachusetts gives us a 95% effective COVID vaccine in 9 months. And it like lots of things, obviously, it's like boosterism for, rivalry, blah, blah, blah. But, and it's oversimplification, but I kind of think there's something to that, like I think the critique of the tech industry that's been like, come on, we were promised all these great things. And, I've got Facebook, I've got some, got these, I think there is some truth and I think just because generally we don't see necessarily lots of innovation doesn't mean that there aren't areas where there's some meaningful things happening. I'm kind of interested in what people think about that. The other question I have is around the interrelation. Again, we're talking about a wide range of industries. The interrelation between the way in which healthcare is delivered and organized, like a state system like the NHS, versus a more private sector one. Because if you look at like 7 of the top 10 pharma companies in the world are US based, 5 of the top 10 medical technology are US based. It's generally seen as the place where it's the most dynamic. And what people would say is if we had a more state run system, you would not see this innovation, that it actually, they're not totally separate, that basically the reason why, you're enabled to get the kind of innovation and technology seen through is that you've got a more market-based healthcare delivery system. And obviously there's loads of good reasons why you'd want to not have the market-based system we have in terms of coverage for people and things like that. But it is a kind of interesting question as to what extent are the two interrelated.
Great, thank you very much. Lots of food for thought there as well. Richard Ings.
Thanks, Rob. Yeah, I think I'm going to follow on a little bit from what James has just been saying, and maybe to pick up on what you were asking earlier, Rob, is that to run with James's metaphor a little bit, if we've got a new priesthood, perhaps we need to introduce some real heresy and a bit of disestablishmentarianism into the discussion. I've been thinking about this as far as the narrative with regards to how COVID is being posed as you're a threat to my health, and that in some ways that if I'm being irresponsible if I don't look after you, if I don't wear a mask, I might be infecting you. And this seems to be something which is kind of inbuilt into the NHS, in some ways into the NHS ethos, which is that we're all responsible for each other's health in some ways. And I actually think that we could do well potentially to actually harness some of the energy which comes from the idea of taking responsibility for your own health and saying, well, actually I need to take responsibility for this. I mean, for the first time in my life, I've actually been looking online for how much it costs to have private care, because quite honestly, I don't want to anymore go into the NHS and be lectured about my health. And since they are considering, or it's being talked about, as it were, sort of informally, the idea that, well, why should you have NHS care if you haven't had a vaccination? And that's not to be anti-vaccination, but the fact that the healthcare system could insist on you having something done before it treats you makes me more and more inclined to think that perhaps the individual solution, the individual responsibility thing, isn't such a bad idea, and that we could perhaps sort of think about exploiting the actual how would I put it, the taste for private or for private thing. I actually think this might be something that to look forward to in terms of the technology. I think I spoke to you about James about this before, which is that if everything's online, why wouldn't you consult the best physicians in America? Why would you go to your local GP for your prescriptions or your thing? So actually the potential for medicine becoming an international thing where you choose your doctor according to his or her qualifications is something that is, I think, a genuine possibility.
Very interesting idea there. Briege, then Alex, and then I'll bring James back in to conclude.
Hi. I'm sorry if I'm repeating anything that was said, because I wasn't able to stay for the whole discussion. But one thing that strikes me is that the NHS has no idea what it's there for. And it seems to me that it attempts, everybody wants to solve social problems through the NHS, just like they do for education and through the police and everything else. And it reacts to the last person that it spoke to most convincingly, or who convinced it mostly, because it has no clear idea of itself, what it's there for and what its role is, which is why it can, as Phil said, there is this very much top-down approach to it, and whatever the centre says should happen, then that's what's going to happen, because you've got yes people all the way down, whose careers are totally dependent on delivering what is demanded of centrally. And obviously that's a real problem. But you can see how it can, despite itself, and impress us all by delivering on the COVID in the last year, notwithstanding that there's huge problems with that. But because it was able to concentrate resources and react to one particular problem, even if the problem was changing all the time, a lot of people were very impressed by it, not least the staff within it, who felt for the first time in a very long time that they were actually doing something useful, as opposed to pushing paper and pretending that they were gathering evidence to demonstrate that they were providing a quality service, blah, 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 which is what a lot of us as pen pushers did for years until we couldn't take it anymore. So you can see that it can do stuff when it's under pressure. It did, when AIDS was a big issue, and AIDS has gone from being something that killed you to being just a long-term medical condition where you don't even have symptoms anymore. And at the moment, we can be tested for COVID and be told within 20 minutes that you don't have any symptoms today. That is really good. But the problem is, like I say, it's reacting to the last person or the last issue that comes up. And obviously no service can operate like that. So I think until it's forced to make a decision about what it's for, is it health promotion or is it treating sick people? Then I think we'll continue to get this mess that we've got, because there is still too much of a reverential approach to it that is just so stymies innovation, because you can't criticize without being challenged for being all sorts of things.
Right. Okay. Thank you very much, Breach. So I've got Alex, Cameron, and then we'll be back to James.
I was brought up by a mother who, anytime I complained there was something wrong with me, says, "Shut up, or I'll give you something to complain about." And the result of that was I tend to save up my complaints before I go to the doctor. Last time I went there, the doctor said, "What can I do for you?" I says, "Well, there's 3 things." And she looked at her watch and she says, "What's the most important?" We've all got horror stories about how we've been treated through the NHS, what a terrible institution it can be. But there are as many celebratory stories. There are as many stories that say what a wonderful institution it is. And there's truth in that. So this might be an annoyingly basic question, which I'll pitch to James. I know that he's been involved in discussions about hospitals while he stood as an MP, but I'm wondering, is it a public discussion? Has the question, the ultimate question that might lead to progress, been asked and is being deliberated by a wider public? And that is the NHS fit for purpose? Because I'm not convinced that question has got through.
Okay, thank you very much. Thank you all. James, I leave you with the unenviable task of picking through all those excellent points and responding to them, just probably 2 or 3 briefly. So the floor is yours, James. James, you have to unmute again, sorry.
There we are. Yeah. Well, it's all very useful. You see, I did learn a lot in the battle about St Helier Hospital and all of that, and I talked to the staff, and you know, I went to the trust meetings and all of that. And the simple thing is that there's a local Labour Party campaign there called CLOSH with a capital K, Keep Open St Helier Hospital, something like that. And they continually posed it in terms of private versus public, cuts, and all of that stuff. And that framework has been going for 30 or 40 years. And they also felt very much that Simon Stevens was a step into the privatization and the Americanization, the Trumpization, I should say, of the NHS. I don't think those arguments ever convinced anybody actually on the doorstep or in the constituency where I got 1,000 votes. It all seemed a bit old-fashioned. Having said that, you know, when we come along, I think we must come along and do the exposure that Jenny says, talk about real innovation and fake innovation. And I'm making Alex Cameron go back to the kitchen toaster. I'm so boring, but that's all right. You know, we must do that exposure, even though we will be cast as Trumpites and all the rest of it, you know, anxious to privatize the service. But the issue for us isn't about whether it's private or public. It's about anything that works. And I think the performance of some of the ventilator makers from the car industry and some of the drug companies and some of the other people involved in the private sector has been estimable. It's just fruitless to, you know, not recognize that point. But if you do, you're going to be vilified for it. So I think the key is that we have to stress that the issues are innovation, democracy, real quality, person to person, often face to face, thanks very much, not IT mediated, not because we're Luddites, although that's unfair to the Luddites, but because we want as Phil was saying, a high quality service with high technology behind it and with highly skilled and therefore highly remunerated workers, not trust clinicians kicked upstairs. We have to pose the questions of democracy, innovation, the workforce, technology, by contrast with health promotion and the new elite, the new priesthood. Can I just ask, some colleagues will know that I've just done a chapter of this book on this question. I'm always asking for Jenny's email, and I think I now want Fenno's. If I could get it from you, Rob, and they're very bashful when I chat to them, or Jenny is anyway. And I do owe a debt to Richard Ings, because it was Richard who pointed out to me that, you know, the discussion on comorbidities has alerted everybody to the connection between lifestyle and COVID. And therefore that's reinforced, I fear, or he fears, and rightly, the health promotion agenda. But if we can counteract that with the call for innovation and democracy and less bureaucratization, I think eventually, you know, the penny will drop. We can just hope for that. Otherwise, we've got real problems.
Okay, thank you very much, James. Now, given all the limitations of Zoom, it's traditional to give our speakers a round of applause. I very, very much ask you to give a round of applause to James Woudhuysen. Thank you very much. I'm going to mute you all again now. Right. Yes. So, yes, thank you very much for your contributions. What I really love about these Academy of Ideas discussions is that they go off in all sorts of directions, because lots of people are bringing their brains and thoughts and whatever to it, and I thought that was very, very useful in a lot of different ways. If you'd like to support us continuing to do these kinds of discussions, please do visit academyofideas.org.uk/support and give us a donation, or even join the Academy of Ideas. That would be great as well.